and terminology is used, and understanding and analysis of various Doppler signals, various types of vascular abnormalities, particularly arteries, few points of clinical interest in various vascular lesions, general peripheral arterial Doppler examination technique and protocol, and characterization of arterial lesions on color Doppler with input of some interesting cases. So, as we know, basic information contained in a Doppler signal are basically presence or absence of flow within the channel we are insonating, direction of the flow, velocity of the flow, and temporal changes in flow velocity. So basically, Doppler ultrasound utilizes a Doppler effect, which is nothing but any moving target is stricken with ultrasound beam. The returning frequency is different from the original insonatic frequency, and this shift is known as frequency shift, and this principle is utilized in Doppler by acquisition and putting it in various aspects of it. So first of all, we examine any vessel in a B mode to see the details of the lumen, the arterial wall, and perivascular structures. Is there any abnormality in the wall, lumen, or perivascular area? So B mode examination is a first step in evaluation, and then we apply the color Doppler application, in which we apply a color box of adequate size, clearly encompassing the vascular structure, and then we can see the colors through it. It is confirmatory that it is a vessel. And on spectral Doppler application or pulse Doppler or waveform analysis, we can see the sample volume. We visualize the artery and put a sample volume in the center of the artery and derive a spectrum. So this is how we can proceed. So color Doppler is basically sampling is done through color box, which samples each pixel of that area and assess the Doppler shift and the superimposed signals of direction assigned with color, that is red towards the probe and blue away from the probe, or vice versa. And shades of color intensity are assigned with flow intensity. The lighter the shades of color, the high will be the velocity. This is how we can assign various Doppler signals on color Doppler in a color box. For example, this is the vessel, this is its branch, and we have applied color box and slanted in this direction. The flow towards the probe is red and away from is blue. So this is branching vessel is showing blood flow towards the probe, and it is feeding this main channel, and this is going away from the channel. So the same vessel and its branches showing abnormal pattern. So this is indicative of some pathological situation, like this is feeder and this is the main superficial femoral artery, which is going to the lower limb. And when any vessel is scanned with color box, this is the laminar flow with the equal density of colors, and there is some abnormal area where we can see lighter signals. This is an abnormal area. Here velocities are high. So this is how color Doppler as well as the direction of the changes. Now, then we sample, we angle, correct the angle. This is a vascular vessel alignment, vessel line, and this is the beam line, steering. This is the vessel angle. It should be kept less than 60. So it is put within the center of the vessel, 2 to 4 millimeter, depending upon the vessel diameter. And the spectrum is displayed over time, and we can achieve a spectrum like this. So basically, waveform is a display of Doppler frequency shift, velocity over time. This is the time, 0 axis. The y is the velocity displayed in various phases of the cardiac cycle. And the direction of is above the baseline is towards the probe, and below any reflection of the spectrum below is indicative of the negative direction or the opposite direction. And the acceleration is a slope, and this is the peak systole. This is how the spectrum of a laminar flow is achieved, and there is a clear spectral window in between, and the thickness of the spectrum depends upon the various velocities in that particular cardiac cycle in the vessel lumen, variable velocities. So this is usually there is a clear spectral window, and this is a narrow band. But when there are alterations in the flow velocity of the vessels of the RBCs, then we can get a different, slightly wide, or sometimes we can fill the spectral window, which we call it as a spectral broadening. So this is a laminar flow normal, where we see abrupt acceleration, peak, deceleration, early diastolic reversal, and throughout the cardiac cycle forward flow. Angle should be corrected, and it should be kept less than 60 degrees to get accurate velocities. At 90 degrees, we don't see any signals, and if it is more than 60, then there is less accuracy. Now, aliasing, another important artifact we encounter during color as well as in spectral display. So in color Doppler, we see aliasing means there are higher velocities. This is a lighter velocity. This area is abnormal. And sometimes if we have first and try to see the clarity of the color flow channel. And aliasing basically it occurs when the Doppler shift is more than half the pulse repetition frequency of the probe. So it should be adjusted accordingly. In a spectral analysis, when the velocity is high than the applied velocity of PRF, then we can see the overshooting velocities will be wrapped down the baseline. So we have to correct it in various other manners. Either we put the baseline down, or we increase the PRF or the velocity range to achieve proper spectrum. So this is very important. Now resistive index is again very important criteria for quantification of the flow and see the quality of the flow. So resistive index is systolic peak minus diastolic peak divided by systolic peak. So if the Ri is less than 1, there is continuous forward flow, low resistance flow. When the Ri is 1, there is no diastolic flow. Ri is less means there is high resistance, and there is reverse and diastolic flow. So Ri signifies resistance of the distal vascular bed. Let us see. So Ri is basically more than, so there is complete diastolic flow, which is indicative of low resistance flow. Here there is loss flow, so Ri is more than 1. So low resistance flow, high resistance flow, and this is high resistance flow. So this is low resistance flow, means continuous forward flow throughout the cardiac cycle. Such arteries which are supplying to the important organs like brain, liver, kidneys, and placenta, these arteries are low resistance arteries because there is continuous forward flow. There is demand of continuous forward flow throughout the cardiac cycle. Whereas there is variable loss in the diastolic flow throughout during the diastole, it is high resistance flow. So certain arteries like peripheral arteries of upper and lower limb supply the muscles at rest, needs less flow. So they produce a high resistance flow spectrum. So according to, this is very important article, according to summary of consensus statement from Society of Vascular Medicine and Society of Vascular Ultrasound, there are certain important criteria has been established for all arterial and venous waveform analysis using certain descriptors and modifiers. Optimization technique should be used to provide quality Doppler waveforms for accurate interpretation. Waveform descriptors and modifiers, velocity measurements, image descriptors are test findings, not the interpretations. So now coming to the consensus points. arterial key measure descriptors. Now we use these terms only these days. So flow direction is very important descriptor. Flow can be antegrade, which is actually the flow within the artery in the normal direction of its normal position, normal situation. Retrograde means flow is in the reverse direction throughout the cardiac cycle in certain pathological conditions. It can be bidirectional, that is systolic forward, diastolic reversal, or there can be absent. So this is how this description is important. Another is phasicity of the spectrum, or phasicity of the flow. Flow can be multiphasic or monophasic. Earlier we used to see biphasic and triphasic. Now it is constant that it is only multiphasic and monophasic. Resistance can be high, intermediate or low. Additional modified terms can be upstroke, which can be rapid upstroke of the spectrum. It can be prolonged upstroke of the spectrum depending upon the pathological condition. Peak can be sharp. There can be spectral broadening, filling the spectral window. There can be staccato flow or the disturbed flow. There can be dampened flow. Earlier we called it a tardus parvus. Now we use this term dampened flow. So these are additional modified terms, and these are the basic measure descriptors while analyzing the spectral waveform. And another important modifier is flow reversal. So flow direction, this is the normal antegrade flow. There is early diastolic reversal, continuous forward flow. This is a normal, multiphasic spectrum of the peripheral artery. When there is pathology, there is continuous reverse flow in that particular artery. In the opposite direction is retrograde flow. There can be bidirectional. There is systolic upstroke in the above the baseline. There can be continuous diastolic flow below the baseline in the reverse direction. So this is bidirectional, and there is no flow or absent flow. Phasicity. These are two spectrums describing. Earlier we call it a triphasic spectrum and a biphasic spectrum. Now we use this term multiphasic. There is one phase in the positive direction, another reversal and forward flow. So the flow is showing three phases of flow: reversal, and again in the mid diastole there is forward flow. This is bidirectional, biphasic, but we use this term multiphasic only. This is monophasic flow. There is continuous forward flow in one direction only. This is continuous monophasic flow throughout the cardiac cycle. Here there is loss in the right diastole. But this is monophasic. We use this term monophasic. Now coming to resistance, these two spectrums are showing high resistance. This is a multiphasic spectrum. This is again a monophasic but high resistance. There is no diastolic flow. It is multiphasic high resistance. This is monophasic high resistance. This is spectrum showing intermediate resistance. There is upstroke, peak, there is deceleration, and it is not touching the baseline. The flow is somewhat there in the diastole, and it is continuous in the forward flow with a dicrotic nose. So little bit moderately resistant, intermediate resistant. That is touching the baseline, again intermediate resistance. And again a monophasic spectrum with good amount of diastolic flow. This is a dampened flow spectrum, again low resistance. So these are low resistive spectrums. These are intermediate resistive spectrums. These are high resistive spectrums. Then another important modifier is rapid upstroke. There is immediate acceleration to achieve the peak systole, and the time taken is acceleration time. There is rapid upstroke in this spectrum with less acceleration time. In a prolonged, we can see in certain pathological condition when there is the inflow is delayed because of proximal pathology, stenotic lesion. There is delayed in the upstroke is prolonged, the acceleration time is increased. Another is sharp peak, and sometimes it is blunted and white. So spectral broadening, when there is complete filling of the spectral window because of the multiple velocities in that particular time filling. This is spectral broadening. These two spectrums, this is low resistance with spectral broadening, this is high resistance with spectral broadening. This is dampened flow. There is delayed acceleration broad peak, and continuous forward flow. This is staccato flow, disturbed flow. There is abrupt achievement of the systolic peak with abrupt deceleration and loss of diastolic flow. So this is, earlier we used to call it a blunted or thumb spectrum, which is seen just prior to the occlusion, before establishment of the collateral flow. And this is flow reversal. Flow reversal means there is reversal of the flow in the cardiac cycle only, some phase of the cardiac cycle, as we can see in cases of steal phenomenon, when there is a need of the blood to the another important artery. The one artery basically supplies to that, and there is a variable flow reversal in various stages of the cardiac cycle. So this is how we see a flow reversal in various pathologies. So points to remember are, every artery has its signature spectrum. A normal spectrum for one artery can be abnormal or pathological for other artery. Some arteries may show altered spectrum with change of physiological state or in pathological states. Arterial spectrum shows status on inflow, that is the upstream, and the status of the outflow, that is the downstream. A little bit about the technique and protocol. Everyone knows, but still let us have a fast view of this. It is important to check referring notes first and accompanying other investigation details, and make a thorough clinical examination of the patient before embarking upon the scanning procedure. And your equipment must be equipped with color, power, spectral, Doppler imaging capabilities. Transducer, definitely linear probe, but for 2 to 5 megahertz for aortoiliac arteries, and linear 3 to 12, 15 or 18, whatever available with your equipment. It is the ideal 12 megahertz probe for rest of the arteries. But imaging settings must be optimized for arterial evaluation by just optimizing the wall filter and velocities and color flow gains and all that. And one must have thorough anatomic knowledge of the tree prerequisite. It is an important prerequisite that you should know the anatomy of the arterial tree of that particular part. We first make initial scanning with B mode for the lumen, for the wall, for the perivascular status. We must optimize the color box size, slanting accordingly. We must optimize gain and PRF for taking a very good color and spectral Doppler spectrum. For a good spectral waveform, again, sample size, position, beam vessel angle, PRF, and spectral gain all are important criteria. And then thorough scanning is done of entire arterial tree or each segment of the artery in transverse and longitudinal planes, with assessment and documentation of all relevant Doppler parameters and various lesions. So assessment includes level, cause, degree, severity and extent of the arterial lesion, status of the proximal, collateral and distal arterial tree. Of course, lesions are common at bifurcation and the branching of the vessels, so be aware of these notorious areas. Coming to abnormalities, can be occlusive, non-occlusive. Occlusive are basically, these are the common causes. Atherosclerosis being the most common for peripheral arterial disease, arteritis or vasculitis, any external compression, embolic phenomenon, Burgers or Raynaud's disease, of course trauma. And non-occlusive diseases of arteries are aneurysm, true and false aneurysm, AV malformations. A bit about clinical symptomatology for vascular lesions and limb ischemia. There can be acute onset of symptoms in which there is sudden occlusion of artery, no time for collateral to settle, so there is abrupt onset of pain, limb is pulseless, pallor, paresthesia, paralysis, and poikilothermia, that is the cold limb. In chronic cases, there is gradual narrowing of the arteriole, so enough time for collaterals to develop. There is usual history of intermittent claudication on exertion or utilization of that particular limb, more tolerant to prolonged ischemia, and critical situation, there is rest pain and gangrene changes. In aneurysmal cases, there is usually pulsatile lump. In arteritis, some symptoms, systemic symptoms are also present along with symptoms of ischemia. So this is how a overall clinical profile of various vascular lesions. Now coming to aneurysm, which can be a permanent localized dilatation, abnormal dilatation of the artery, focal enlargement more than 20%. Neural factors are important, primary cause, like vasculitis, atherosclerotic, degenerative processes, and so on. Sometimes mechanical factors like post-stenotic aneurysm can also develop because of the stenosis. There is post-stenotic dilatation. It is a potential source for thromboembolism and rupture. So this is a lady having a pulsatile swelling in the arm. So this is a slow video, brachial artery showing eccentric dilatation and continues with the vessel with a large mural thrombus, thrombotic aneurysm of the brachial artery. It is continuous. On color Doppler, we can see the disturbed flow in form of a yin-yang type flow. It's a disturbed spectrum. So this is classical of vascular dilatation, that is aneurysm, in which the wall of the vessel is two walls. Another important case with pulsatile non-tender ventral wrist nodules confused with ganglions, but we can see small degenerative changes, calcification with dilatations in the radial artery just prior to the wrist. Again, there is dilatation of the ulnar artery with a large mural thrombus, thrombotic occlusion. There is flow. It is continuous with the ulnar artery. The wall is clear. So this is potential source for distal finger and distal embolization. So a case of radial and ulnar artery aneurysms in atherosclerotic disease. Pseudoaneurysm is basically false aneurysm as a result of perivascular cystic mass with blood flow and signals. Most common cause is penetrating trauma or post-intervention. On color, we can see swirling motion within the cystic mass with the yin-yang sign on color. And on spectrum, we can see to and fro flow, that is to and fro reversal in the diastole flow at the communicating channel. This is a case with ulnar artery trauma. There is a swelling at the wrist, ventral wrist, with liquid blood flow moving on real time. There is a color flow signal on color Doppler application. Sorry. This is the ulnar artery. There is a communicating portion which is showing aliasing. And on spectral Doppler analysis of this particular area, which shows forward flow and reversal flow, forward flow and reversal flow, typical to and fro flow, which is typical signature of the neck of the pseudoaneurysm. The wall of the aneurysm here is false because of the soft tissue and fibrosis. So this is known as pseudoaneurysm. Now, AV fistulas are basically abnormal communication between the artery and vein. They can be congenital, iatrogenic, or post-traumatic. So low distal resistance flow in the feeding artery. Feeding artery will become low resistance because it is communicating with the venous channel, which is low resistance channel. And we appreciate very high velocity turbulent flow in the draining vein, which does not cease on Valsalva. There is no any Valsalva changes in the draining vein. And we can see continuous turbulent high flow in the communicating fistulous channel. Let us take example. This is male 60-year, post-PTCS, small swelling with fill at the wrist, ventral aspect of wrist. This is radial artery. This is the accompanying vein. There is communication with aliasing and some clutter and the noise adjacently. This is the communicating channel. At the communicating channel fistula, we can see high velocity, low resistance flow. The diastolic velocity is the peak systolic velocity achieving 250. There is continuous low resistance, high flow. The draining vein becomes pulsatile. And the feeding artery is markedly low resistance. Normally it is high resistance multiphasic spectrum, but there is low resistance plus flow. So it is a case of post-PTCA, AV fistula of radial artery and vein. Now, malformations are basically abnormally arranged vascular channels in a soft tissue. They can be developmental, and they can be high flow AV malformation or slow flow venous malformation, or they can be mixed. So this is a young girl with small swelling at the scale. There is a soft tissue mass with multiple cystic and tubular channels. On color Doppler, we can see these channels are showing tremendous, vascular signals on color Doppler. And on spectral Doppler, we can see low resistance high flow in the arterial and low resistance high flow in the venous channels becomes arterialized. So this is a typical high flow AV malformation of the scalp. Again, another young female with a small swelling growing with the age in the forearm. So there was a irregular heterogeneous mass in the forearm involving deep subcutaneous and intramuscular plane with multiple abnormal loculas with some calcific foci within it. Some locula shows, echogenic material, that is cystothrombosis, and these are the typical phlebolids. On compression, there is some movement of the vas flow which indicates slow venous flow. So this is nothing but a slow flow venous malformation. Now coming to another entity of vascular occlusive disease, atherosclerosis is most common. There can be focal thickening or there can be diffuse atherosclerosis. Focal thickening is known as plaque or atheroma. It is seen most common at origin in bifurcations. Diabetes is again a predisposing factor. Calcification is more common in media of the vessels, casting shadowing, and it causes difficulty in scanning of the arteries. Now plaque or focal plaque can be homogenic, heterogenic, smooth, irregular, ulcerated. If it is ulcerated, it can initiate local thrombosis and it can initiate variable degree of stenosis. So atheroma on B mode can be seen as very homogenic intraluminal projecting mass focally, reducing the lumen with a smooth margin. On cross-section area, we can measure in the diameter method or cross-section, we can measure the stenosis. It is approximately 60% stenosis causing. Another vessel with a calcification in the plaque, with distal reverberation causing difficulty in scanning. We cannot say that it is occluded or not. So it is a calcifying plaque. In this vessel, we can see a irregular, heterogenic, ulcerated, marginated plaque, which is very dangerous. It is a potential source for local thrombosis and occlusion, and distal rupture of the plaque and distal embolization, distal thromboembolism. Again, plaque with irregular internal outline with a depression, which is typically ulcerated plaque. It is again a very dangerous plaque with potential source of thrombosis. Now, diagnostic criteria of plaque 1 stenosis on color Doppler. There is focal thickening on B mode. Color flow channel is narrowed with aliasing and mosaic flow. Color root can be seen due to vessel wall vibrations. And the spectrum shows increased PSV with spectral broadening, which is typical of stenotic flow. And there is post-stenotic dampened flow spectrum. Let us see. This is a normal flow. There is narrowing of the channel. There is aliasing and mosaic pattern. Transverse plane, there is luminal narrowing. The color brute is because of the vibrations in the vessel wall to the adjacent soft tissue, which is seen on real time as these clatter and noise, which is indirect evidence of a high-grade stenotic lesion with vibrations in the vessel. And spectrum, we have to optimize because there are high velocities. So either we lower the baseline to overcome this aliasing effect, or we increase the PRF or velocity scale to achieve proper spectrum. So this is normal peripheral arterial spectrum, which is multiphasic. In the stenotic area, there is abrupt systolic peak, high velocities, complete filling of the spectral window, good diastolic flow, high diastolic velocities. It is typical stenotic flow. And there is dampened flow in the distal to the stenosis in the downstream artery. So flow velocity changes are basically in stenotic area, there is high velocity, there is spectral bonding, high diastolic frequencies. So it is important to ascertain accuracy of the color Doppler for detection of the stenosis if more than 50%. We see first peak systolic velocity prior to the stenosis, and then we see the stenotic velocity PSV, and then we calculate a ratio. If it is more than 2, ratio is more than 2, The stenosis is 50% and more. If the ratio is 3 or 4 times, if it is more than 4 times, the velocity is more than 4 times the pre-stenotic velocity, then it is high grade stenosis, that is a stenosis more than 75%. So let us see the case. 60-year diabetic hypertensive male with history of right calf claudication. So this is superficial femoral artery showing irregular dense calcific plaques with distal shadowing. We can't see anything. Put color Doppler, there is clutter, there is aliasing, there is mosaic pattern. So we have to optimize the color flow. We reduce the color gain and then we increase the PRF. We can see there is narrowing channel, there is turbulent, the plaque is there. In the same site, we can see high velocities 540 centimeter. More than ratio is more than 5, and there is dampened flow in the distal popliteal segment and the upper anterior tibial and posterior tibial artery. So in this case, there was only high-grade stenotic lesion in the adductor canal due to focal plaque disease, and it is a suitable case for intervention for angioplasty and stenting because rest of the tree, downstream tree, is normal. Now coming to occlusion, the diagnostic criteria includes absence of flow signals on color or color void in the segment affected, echogenic material within the lumen causing occlusion, large vessel collateral takeoff just proximal to the occlusion, proximal vessel show high RI flow, and just proximal to the occlusion we see staccato or the thumb spectrum or plantar or disturbed flow spectrum, and distal we see dampened tardus parvus or low amplitude flow with pen-diastolic flow. Let us see. So this is the popliteal artery in an acute thrombotic occlusion. You can see a clear-cut interface. This is a normal lumen. This is the echogenic material. On color, we can see abrupt cutoff, no flow in the thrombotic area. So there is abrupt cutoff. Another example, this case after MI after some time developed a lower limb ischemia, and there was an echogenic embolus occluding the popliteal artery, mid-segment of the popliteal artery. This is a dense embolus. This is seen because of the rupture of the calcified plaque somewhere in the heart or some other proximal source. So occluding the popliteal artery. This is a thromboembolic phenomenon. Now there is pre-occlusive collateral takeoff is an important sign in color Doppler. Just this is occluded vessel. This is proximal collateral takeoff. This is the flow within the collateral. This is the staccato flow in the pre-occlusive status, pro-occlusive part, and there is distal flow is dampened flow. Distal after revascularization with the distal vessel. This middle-aged lady developed acute history of pain and swelling with cold, numbness, rest pain, with some ecchymosis. Asked for arterial Doppler of the upper limb. There was a thrombotic occlusion. The wall is normal, but it is homogenic thrombus is occluding it at the bifurcation. This is the collateral takeoff, abrupt cutoff. On real time, we can see on B mode that this is the zone of transition. And similarly on color Doppler, we can see the cutoff and the collateral takeoff. So this is ideal. Immediate intervention was done and thrombectomy was done and patient became all right. Another case, male 65 with lower limb claudication, now developed sudden increase in the pain. The left iliac artery did not show color flow signals, heterogenic thickening with intraluminal echogenic material, suggestive of some occlusion, abrupt cutoff, stochastic flow. The femoral artery is also showing irregular plaque with significant narrowing of the lumen, and the femoral artery is showing dampened flow, that is gradual peak acceleration time is increased and the widens peak, typical of post stenotic flow. The same patient is showing again narrowing of the superficial femoral artery in adductor canal with a high grade stenosis. The stenotic flow velocities are high, and the same patient is having posterior tibial artery, upper posterior tibial artery occlusion and refilling via collateral with distal dampened flow distally, And even the dorsalis pedis artery was again showing narrowing in the distal arm. So there was multi-level disease in this patient. For example, atherosclerotic plaque and thrombotic occlusion of the external iliac artery, atherosclerotic plaques with significant narrowing of the femoral, atherosclerotic plaque in the superficial femoral artery adductor canal with high-grade stenosis, narrowing and occlusion of upper PTA, and narrowed DP. So this is a multi-level disease. Now coming to another important entity, that is Burz's disease. It is basically thromboangiitis obliterans because of inflammation and subsequent blockage of the smaller and median sized arteries involving leg and arms. It is rare disease, of course, and mostly seen in young between 20 to 40 years of age. And these are usually smokers. Leg arteries affected more than the arms. Multiple limbs can be affected. Clinically, there is claudication, ulceration, and gangrenous changes. On ultrasound, we can see narrowed segment with hypoechoic wall. Typical tram-trach like we will see in the cases. No calcification, no atherosclerotic disease. Hypoechoic interluminal thrombi, corkscrew collateral. These are hallmark of Burz's disease because these are the vascular maintaining channels because of the occlusion of the smaller segments. These developed as a corkscrew collaterals. There can be intervening normal segments of the vessels and associated phlebitis migrans. So this is how we can see a small narrowed artery with a tram-trach sign, hypoechoic wall with very much narrowed lumen of the small artery. And when there is occlusion, there is abrupt onset of tortuous corkscrew collaterals, and there can be segmental involvement. This is normal refilling. This is again blood flow. There is a segmental occlusion of that. So these are narrowed channels with occlusions, collaterals, and typical appearance on V mode. Let us take example of Burz's disease. 36-year male, chronic smoker, developed rest pain and burning sensation of the toe, gangrenous changes in the right foot, femoral artery normal multiphasic, superficial femoral artery normal multiphasic, popliteal artery intermediate resistance, that is the low resistance flow, diastole reversal is lost, suggestive of some downstream vascular bed changes, offering a low resistance bed. There is PTA, posterior artery is narrowed, typically narrowed. There are thrombi, there is no flow, there is collateral takeoff, there is refilling. This segment is totally narrowed and occluded with vessel wall thickening and intraluminal thrombi. Multiple corkscrew collaterals are present in the leg region to overcome the occlusion. The same case is showing anterior tibial artery segmental narrowing also. Distal dampened flow in the anterior tibial artery after re-establishment. And again, dorsalis pedis artery also narrowed and occluded. So there is multi-level disease in this case. So areas of segmental narrowing and occlusions with interluminal thrombi involving lower anterior tibial artery, posterior tibial artery, and dorsalis pedis arteries, associated multiple corkscrew collaterals. In view of the Doppler findings, young age, smoker, it is classical of Burz's disease. Now another case, 20-year young boy with weakness and some pain in the both lower limbs while running and playing. That is exertional claudication in this young boy. And he was hypertensive also. BP was 150/98. Now femoral arteries, lower limb arterial Doppler was asked. The femoral flow is abnormal. On left side, again abnormal. This is monophasic. The velocities are less. So it shows some upstream pathology, limiting factor. Aorta was scanned. There was a dampened flow in the abdominal aorta with monophasic spectrum. The epigastric arteries, inferior epigastric arteries were dilated and showing significant blood flow and supplying the femoral arteries. These are the right inferior epigastric artery, lower inferior epigastric artery of the abdominal wall, lower abdominal wall, both sides, with multiple tortuous venous channels in the rectus muscle on either side, coming from the chest wall. So multiple vascular prominent vessels in the chest wall, in the abdominal wall, in the draining into the femoral vein through these epigastric vessels, and lower flow in the abdominal aorta. Now, carotids were normal. Both sided carotid artery was showing normal. Means there is obstruction of the aorta distal to the and the radial arteries were also normal, distal to the origin of the subclavian arteries. So typical, these features are typical of the coarctation of the aorta. There is narrowing, and these channels from the chest wall and abdominal wall through rectus sheath draining into the femoral vessels, supplying through these inferior epigastric arteries to supply the lower limb. So again, another companion case, male 50 with developed sudden onset of pain, weakness in both lower limbs with absent femoral pulse. There is acute onset of the lower limb ischemia. Femoral flow is, low resistance monophasic. No flow in the iliac vessels. The abdominal aorta is occluded by a thrombus. So basically there is a thrombosis and occlusion of the lower abdominal aorta extending to involve bilateral iliac arteries, classical of thrombotic occlusion of the lower abdominal aorta and iliac arteries, typical of lyric syndrome. Again, another companion case, low altered spectrum in the femoral artery suggests some proximal pathology. Again, aorta was scanned. There is massive color bruit. The color settings were optimized, and there was a high-grade stenotic lesion with high velocities of the aorta. Rest of the limb was normal. So it was lower abdominal high-grade stenosis. Again, a very good case for abdominal angioplasty and stenting. Another companion case, a 6-year female with pain abdomen, hypertension, weakness in both lower limbs on exertion, malaise, low-grade fever, and weak femoral pulse. The symptoms are very important. The patient was sent for abdominal ultrasound. I see the abdominal aorta was thick-walled. There is concentric thickening of the abdominal aorta. On color Doppler, we can see this hypoechoic halo, macaroni-like sign because of the concentric wall thickening of the aorta. On color Doppler, we can see narrowing of the abdominal aorta with aliasing narrowed channel and high velocities, high stenotic flow. The same case also showing significant narrowing of the right renal artery and left renal artery with marked thickening of the wall. Again, halo sign of the aorta, halo sign around the renal arteries, leading to renal ischemia and hypertension. So this was basically case of Takayasu aortoarteritis or pulseless disease involving abdominal aorta and bilateral renal arteries, causing renal artery stenosis and abdominal aorta stenosis. So basically vasculitis or Takayasu arteritis is a rare chronic inflammatory disease of the aorta and its major branches because and there is inflammation of the wall. Granulomatous disease usually affects young females, and we will see non-specific systemic signs like weakness, malaise, vertigo, weight loss, headache, and so on and so forth. And some symptoms are related to vascular ischemia of that particular vessel involved. The diagnosis can be done on the basis of NGO, MR, CT, and color Doppler. As we have seen in this case, we utilizing the color Doppler. There is always concentric wall thickening with luminal narrowing of variable degree, and treatment is steroids, immunosuppressive, and surgical interventions in the severe disease. Now coming to vascular trauma, there is always a technical limitations because of the injury. There can be large hematoma which may prevent direct visualization of the vessel. But it is important, sometimes we can differentiate extrinsic compression from lacerations and vasospasm. So color Doppler is again very important in evaluation of the vascular trauma to see compartment syndromes, vascular laceration, pseudoaneurysm formations, or there is just vasospasm. It is also important for planning of surgical vascularization. We can detect the location and severity of the arterial lesion we can calculate the adequacy of the inflow, and we can identify the distal target vessel for bypass graft. These are the criteria we have to assess prior to surgical revascularization. And for post-op surgical grafts, we must see the patency of the graft, for any graft occlusion, for any stenosis at proximal or distal anastomosis site, or any evidence of perigraft collection, seroma, or hematoma. So this is a case of superficial femoral artery occlusion with femoropopliteal bypass graft. Very old case with me. So it was sent for, there was ischemia again developed in the graft is seen collapsed, and there are proximal site, it is occluded. There was no flow. There was thumb spectrum or staccatic flow here, suggestive of there is occlusion of the proximal anastomotic side of the graft. Another case of bilateral femoropopliteal graft because of the severe occlusion of the bilateral superficial femoral arteries in adductor canal. Bilateral femoropopliteal graft were done, and again patient developed pain in right lower limb. So this is how the graft looks on ultrasound. The right graft was again narrowed and occluded. There was no flow within it, whereas the left graft was showing flow within it, but there is turbulence and aliasing, suggests some stenotic lesion at the anastomosis. No flow in the right graft, and there was a flow within the left graft. So this was the status. Again, the graft was occluded on right side. Needs again a surgical intervention. So this was a case of right graft occlusion, left graft stenosis at the proximal site, anastomotic site. So just to conclude, I would like to say color Doppler is an important non-invasive modality in evaluation of peripheral arteries, including diagnosis of various arterial lesions, assessment of hemodynamics in limb ischemia, documentation of flow limiting lesions, various lesions, planning for treatment, and for post-surgical workup. So this is the beauty of ultrasound. We can see the plaques, characterize the plaque. We can see on color the narrowing stenotic lesions. We can see the stenotic flow, pre-occlusive thumb, occlusive lesions, aneurysms, and all that. So thank you very much for your kind attention. And this was, I try to make it so simple to make you understand the value of color Doppler in evaluation of peripheral arteries in various pathologies, including the normal hemodynamics, the abnormal waveform characteristics, their analysis, various type of flow spectrum changes, various pathologies on beam motions, on spectral, and various ways of quantification of flow changes through my case studies. Thank you so nice for giving me this opportunity to share my experience. Thank you, and over to you, Chairman.
Thank you so much for that awesome presentation. It was loved by everyone, and we can see the positive comments in the chat box as well. There are quite a few questions in the Q&A. Would you like to go through them, sir, and pick and choose the ones that you want to answer? You want me to put across?
Oh.
Yeah, sure, sir.
Yes.
The first question is, if monophasic flow is seen in ATA and PTA, as well as dorsal pedis, with normal velocity and triphasic waveform in upstream arteries, how to interpret that?
When there is monophasic flow with the adequate velocities and abrupt, achievement of the peak systole, this basically inflow. There are inflow vessel or the proximal vessels are okay, and the resistance is low because of the distal vascular bed, which might be affected because of the digital or some palmar branches which are compromising in a different ways, or there can be some inflammatory process going on in the distal area of the part affected, leading to more requirement of the blood, offering low resistance to make it monophasic. I think clear?
Yes, sir. Thank you. The next is, I think you mentioned the dampened flow is same as Parvas Stardust.
Yes. Now this is the term. Now we are using the terms dampened flow.
What is the difference between duplex and triplex Doppler? Is there anything that's triplex Doppler? Is there a difference?
Basically it was the B mode only available. Now then color Doppler and then the spectral pulse Doppler. Pulse wave Doppler. Initially we call it a pulse wave Doppler. When we can sample the blood vessel through the sampling gate or range gate, and we can elicit the spectrum without color. It is a duplex, and now it is color is also available. I did my MD at that time. There was only duplex available, only pulse wave we can put, no color Doppler facility was available. So basically triplex is basically utilizing all three, color as well as the spectral analysis at the same time in evaluation of any vessel. Right?
Yeah, thank you, sir. The next question is how to achieve good PRF and spectral gain.
How to achieve
a good PRF and spectral gain. A good PRF and spectral gain.
The one important thing is PRF is different thing, spectral gain is different thing, and color gain is different thing. First we see the vessel, then we put color box. If the PRF or the velocities are quite low, then we can see mosaic pattern and the color bleed outside the vessel. So first we have to regulate the PRF. We increase the velocity so that the velocity is abrupt, the clutter or the noise will be cut, and then we can improve the color gain to see the appropriate color. So this is how we adjust the color gain in case of color Doppler imaging. If suppose the velocities are high, as we can see here, and the PRF or the velocity range we are applying at the time of examination are quite low, then we can see turbulence, just brute as well as the mosaic pattern. So first we have to improve to cut the clutter and the aberrant velocities. We improve the PRF so that the intensities will be accordingly adjusted and acquired by the color, and then we adjust the color if needed, then to avoid the color bleed. So both are needed to optimize the color image. As far as the spectrum is concerned, when the PRF is low at the time of application of insonation of any vessel and the velocities are high, then again we see aliasing, in which the higher velocities will be wrapped below the baseline and you will not achieve a definitely good spectrum to interpret. Then there are two ways for it. Either we we lower the baseline, or we increase the PRF, so that the majority of the blood flow velocity is catched by the PRF. PRF will be doubled. So it will pick the flow signals of that particular sampling area. So there are two methods, and another important is spectral gain. Spectral gain is basically the bandwidth of the spectrum. Normally in the triphasic spectrum, when the flow is parabolic, the most of the velocities in the center part of the vessels are running with the highest velocity, whereas in the periphery there can be some lower velocity. So there is a parabolic flow, and the spectrum is achieved with typical multiphasic appearance depending upon the velocity and the vessel we are insonating. So when there are noises there in the area other than the spectrum, we have to cut it. So we have to just improve the spectral gain. So it will become more prominent. The whiter part of the band will become more appropriate, and the clutter will be diminished. We can see black area here and white area here. And if the gain is too low, then we can see this area is also putting white signals, and another this is also missing, and sometimes it is very difficult to achieve a good spectral waveform. So this is how all three are adjusted according to the site of examination and the vessel we are viewing and the status of the flow status of the lesion.
Thank you, sir. On the same lines, can you explain spectral broadening?
Right.
I want to go back to a slide and show them also it's okay, sir. We are still sharing a screen.
So basically, spectral broadening is spectral window. We can call it a spectral window when there is okay. So this is a typical multiphasic spectrum of peripheral artery. The bandwidth of the spectrum is very thin. The white line is very thin. Here it is somewhat thick. So there is a clear window between the upstroke and the deceleration, the downstroke. So it shows that the most of the velocities running at the time of this cardiac cycle, systolic peak, are mostly sampled in the center area, and they are having almost equal or very less variation in their velocity. Right from, if there is 100 centimeter per second, these are between 90 to 100 centimeter per second. But in this area, the channel is narrowed and it is having a post-turbulent area, so the velocities are chaotic. The RBCs are very chaotic, and we are sampling the area where, in the stenotic area, we are seeing continuous forward flow. So there is a continuous diastolic flow, and just caudal to it is very difficult to put sample in the exact site, and sometimes we are in position to put a sample just distal to the stenotic side where the turbulent flow is there, where the mosaic pattern is there. So mosaic pattern indicates variable velocities. So at the time of sampling, multiple velocities are there. So the spectral bandwidth will be increased, because at the time of here, at this time, these are the velocities very less at this time, peak of time. This is time and this is velocity. And at this time, you can see the peak RBC flowing rate, intermediate, low, 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 and here the RBCs are very low. So it will fill, because it on the y-axis, these show basically number of Rolex formation, number of RBCs running with variable velocity. So this will fill the window, and this spectral broadening indicates disturbed flow. We can call it a turbulent flow, disturbed flow. Now we use this term spectral broadening only when there is filling of the window, the bandwidth is increased, and this is typical seen at the disturbed site or the stenotic site or post-stenotic turbulent site, right?
Thank you, sir. So can this spectral broadening be without any pathology in the vessel?
Yes. Okay. For example, this is the normal spectrum of the peripheral artery at rest. If you ask the patient to clench the fist or just make the movement of foot vigorously for some time, so in the resting phase, there is very less need of the blood in the muscles. When there is exercise, there is more need. So there is diastolic increase in the diastolic flow velocity. There can be loss of early diastolic reversal. There can be continuous flow within the vessel. And again, the RBCs are running, and there is constant demand of the blood throughout the cardiac cycle. The multiphasic spectrum become monophasic, and the bandwidth will be increased and spectral window will be less. So this can happen in pathological situation as well as in some physiological situations where there is continuous need of the blood to the target organ or target tissue, right?
Thank you so much, sir. The next question. There are a lot of questions for AV fistula. I think we should keep a fourth session in your series on AV fistula, sir. Should I leave the
Okay.
questions for now, because there are at least half dozen questions in AV fistula? Or you want to take them now?
Pardon?
You want to take the questions on AV fistula now, or should we leave?
We will take it some other time. Okay.
So the next question is: should digital vessel be routinely examined in patient with non-healing foot ulcer, or are there any signs which, or are there any signs proximally in which case we should examine them?
Every patient with lower limb ischemia or upper limb ischemia, there is history is very important. Again, whether there is acute onset or there is chronic onset, what are the status of the resting pain or trophic changes are there of gangrene or not. So in case of digital changes like gangrenous changes in Burz's disease or diabetic foot, it is prime important assessment to evaluate the major vessels first up to ankle level. If you find significant pathology in femoral artery or iliac or popliteal artery itself, having like occlusion, and the distal flow in the leg arteries or the foot arteries will be very low velocity monophasic spectrum. So there is the flow is already very much compromised through the major lesion. So it is always important if all the vessels like popliteal leg arteries are normal, and then it is most commonly seen in diabetic foot. Sometimes you see but diabetic foot again pathology can be multi-level. So digital vascular evaluation should be done ideally in every case, no doubt about it, but sometimes the compromising pathology is there in the leg arteries, popliteal or femoral. So there is a hardly very limited flow in the dorsalis pedis and posterior arteries. So I don't find there is need of because major intervention is must. So role of color Doppler is to to assess the limiting disease first in the major vessels, whether it is atherosclerotic plaque, whether it is a complicated plaque, whether it is a thromboembolic phenomena, or it is a single level disease, whether it is a multi-level disease, so on and so forth. Right?
Yeah. There are a couple of questions who are asking, couple of people who are asking, is monophasic flow and dampened flow same, or if not, then how is it different?
No, monophasic. Take this example. There are same limb femoral artery showing multiphasic. There is early diastolic reversal, continuous diastolic, early diastolic reversal, less as compared to this. Popliteal artery showing intermediate resistance monophasic. This is monophasic. This is multiphasic. This is multiphasic. And dampened flow is different. Dampened flow is always a monophasic. Let us go back to the phasicity. So this is biphasic, this is triphasic. Now we call it a multiphasic. There is no question. Earlier, this is monophasic. Both are different. There is no flow in the diastole, but the flow is there in the one direction only. Throughout the cardiac cycle, there is no same flow, but it is on the single direction. Above the baseline, that is continuous forward flow in a single phase, in the monophase, positive side. But here there is continuous diastolic flow present. Both are monophasic.
Thank you so much, sir, for answering that so clearly.
So it depends upon basically the clinical situation in at that time and in the vessel examine.
Thank you, sir. There are a couple of people who are asking B by A assessment.
What is that? Break.
Sir, kindly explain B by A assessment.
Brachial ankle index.
Yeah, I think so. Yes, sir.
So basically, a screening. This is a screening. This is a screening criteria for ankle brachial index is a screening criteria for identifying peripheral arterial disease, in which the highest ankle blood pressure measured as either at the dorsalis pedis or posterior artery divided by the highest brachial systolic blood pressure. Measurement must be done obtained from both the arms. And in patient with peripheral arterial disease, ABI of 0.9 or less at rest. However, normal resting ABI in a patient with suspected claudication should prompt further investigation as post-exercise ABI. So likewise, it is a screening tool to see the blood pressure status of the upper limb as well as in the lower limb. We have seen couple of cases of abdominal aortic pathologies in which there was low pressure within the femoral arteries, maybe because of coarctation, maybe because of aortic thrombotic occlusion, maybe because of aortic aortoarteritis, maybe because of aortic atherosclerotic stenosis, maybe because of aortic occlusion, or maybe because of iliac pathologies of stenosis, occlusion, or other causes. So it is basically a screening tool prior to examination. Ankle brachial index.
Thank you, sir. Now, can you explain the waveforms that are seen in collateral vessels if the main vessel is obstructed? Is there any typical waveform for the collaterals?
Okay, let us take example this is occluded segment, this is proximal collateral takeoff. If we sample here proximal to occlusion, we see high resistance flow because there is resistance, there is complete occlusion. If this channel has developed, then there can be some forward flow. It will be of intermediate resistance because flow is going. If this is sampled, as in this case, we have sampled this collateral and we show there is abrupt velocities are all right. With a 75 centimeter per second, they are going to the collaterals, then refilling established in the distal part. And this is a pre-occlusive spectrum, and this is distal to the occlusion. There is collateral and then again re-establishment of the distal vessel, which will show again a monophagic spectrum. Here the velocity will be less, the time taken to achieve the peak systole will be more, and there is continuous forward flow because of the distal vascular bed resistance. So always collateral flow is always monophasic, most of the time monophasic, and the velocity depends upon the upstream vessels and the resistance depend upon the downstream resistance, vascular band resistance. So collateral flow is always monophasic, always monophasic. You can call it a Tardus Parvus type or a dampened flow.
Thank you, sir. How does respiratory physicity and cardiac physicity affect the Doppler study?
Respiratory physicity is important for venous evaluation also because they are more sensitive for the respiratory physic variation. Arteries are so strong, very thick walled. The respiratory physicity is not much affecting, but cardiac cardiac status is very important in arterial evaluation because it is the ejection fraction, it is the pressure created by the left ventricle during systole is all important, because when heart is failing we can't expect much velocities in the peripheral arteries itself is compromised. So there is always the vascular bed is low resistance to the periphery. There is more hunger of the oxygenated blood. So there is always monophagic sort of flow in the arteries, and so cardiac status is very important in basically spectral wave analysis as well as in the hemodynamics of the arteries.
Thank you, sir. The next few questions are with regards to physics. How to do angle correction and steering, and how to place how to align the color box along the vessel.
Okay. If suppose this is the tubular structure, first we put color box and see the color gain, optimize the color gain, see the parabolic flow. So this is the direction of the vessel line. This is the vessel line. And this is the insonatic beam. This is the range gate or sampling volume. So first we have to align the angle, keeping it minimum. If it is 0, it is very good. If the vessel is dipping like this and we are insonating the same direction, the accuracy will be very good. But sometimes it is not always possible. When the vessel is slightly slanted, then we try to slant the color box maximum, and then steer the beam. If it is causing angle less than 60 degree, it's all right. If the vessel is suppose like this, then we have to angle correction like this, but it should not be, it should be, angle should be from the line of the vessel. It should be, this is the angle. It should be kept less than 60 degree. So steps are, first slant and steer the color box, then steer the beam, then steer the angle to optimize the spectrum.
Thank you, sir. There are a few people who are asking the significance of wall filter and how can it alter the results.
It will produce noise, clutter. So we need basically good color flow image, and it will, the spectrum will be very much distorted. There are multiple, abnormal frequencies in the spectrum. So we cannot basically make out the sharpness of the spectrum and for interpretation. So first of all, it is important to adjust the wall filter to avoid the clutter and noise, and then PRF, and then the frequency of the transducer, again very important, and then the PRF and the appropriate gain, whether it is a spectral gain or it is a color gain. Right?
Yes, thank you. Now, okay. Is there a chart or any values for lower limb fixed systolic velocities? Like what is the?
They are available. These are available in literature. Basically, one can see. Normal velocities are always variable depending upon the cardiac status. So normally, basically values are available normally in the femoral 120 to 100 to 180. There range, definitely range is there. So and so normal, there is definitely normal range of the vessel peripheral arterial blood flow peak velocities in upper limb as well as in lower limb. But these velocities depend on cardiac status and cardiac rhythm.
Okay, thank you, sir. What is the significance of acceleration time?
Right. This is a multiphasic spectrum. There is onset of systole. This is the peak systole. This is the acceleration time. So time taken to achieve the peak systole is this much, whereas the time taken to achieve the peak systole is this much. This is more. So any spectrum, this part of the spectrum is very important for for inflow of the vessel, that is upstream vessels, and this part of the spectrum is for the downstream flow or the outflow. So when there is proximal severe limiting disease or high grade stenosis, there is always compromised channel. So the prolonged upstroke is there at the time of in the sampling vessel. So this indicates upstream pathology, severe stenotic lesion proximal to the site of insonation.
Thank you, sir.
And this is deceleration or the and this is the diastolic flow. This indicates the downflow, downstream arterial system. When there is low resistance, more diastolic flow. So every spectrum indicates the acceleration time practically indicates the proximal tree status. Right?
Yeah, thank you, sir. What is trickle flow? Is there a term like trickle flow or?
Trickle flow, trace flow. I think. What does it mean? I don't know. Trickle flow.
Okay, thank you, sir. The next is, are there any specific Doppler changes in compartment syndrome and Raynaud's? A similar question.
In Raynaud's disease, actually, just